Good afternoon, everyone. My name is Matt Kennedy, and I'm a surgical nurse practitioner. Today, I'm presenting the findings from our audit entitled, "Is more education needed to streamline the referral process for PICC line placement in the acute surgical division?" This project was undertaken as part of our advanced clinical practice dissertation and in collaboration with my colleague, Beth Hayes. The project stemmed from concerns raised within our surgical division about inconsistencies in how peripherally inserted central catheters were being requested, assessed and inserted. We wanted to explore whether these issues were linked to gaps in education and communication across the multidisciplinary team. PICC lines are commonly used in surgical settings for long-term intravenous therapies such as antibiotics, chemotherapy or total parenteral nutrition. However, their insertion is not without risk and cost implications. Each procedure requires specialist staff, imaging resources and carries potential complications like infection and thrombus. We noticed an increasing number of referrals that were being questioned by the vascular access team, either because the indication wasn't clear or because other less invasive options might have been more appropriate. This prompted us to ask, are some of these referrals inappropriate? And if so, what's driving that? Is it a lack of knowledge, unclear criteria, or poor communication? By addressing this, we hope to improve both clinical outcomes and operational efficiency within our division. Our audit therefore set out to identify the proportion of inappropriate PICC line referrals and insertions within a 1-month period, assess the reason for these inappropriate placement, explore barriers to effective referral processes among surgical nurse practitioners and medical teams, and finally, develop strategies to improve education and standardise the referral pathway. Essentially, we wanted to combine data with insight from staff to propose practical, sustainable improvements. We conducted a 1-month retrospective audit within the acute surgical division. All PICC line referrals and insertions during that time were reviewed using a standardised data collection tool. Each case was assessed against our Trust PICC line criteria and the national guidance for TPN and long-term IV therapy. We also recorded who made the referral, whether the nutritional team was involved early, and what the documented indication was. Where data was unclear, we followed up with the referring team to clarify their rationale. In addition to the numerical audit, an informal discussion was held with the surgical nurse practitioners and junior doctors to explore their understanding of referral pathways and any barriers they experienced in liaising with the nutritional team. So the results. During that 1-month period, there were 23 PICC line insertions within the surgical division. Of these, 4 were found to be inappropriate. That's representing 17% of the total. The estimated financial cost of these misplaced lines, based on equipment, staff time and radiology resources, was approximately £2,050. When we analysed the reason for inappropriate referrals, 2 clear themes emerged. 1. Lack of early communication with the nutritional team. And 2. Uncertainty among staff regarding TPN criteria, particularly when deciding whether a patient's nutritional needs could be met enterally rather than via a PICC line. Many practitioners reported that they were unsure when to involve the nutritional team and didn't always have access to clear guidance or training on the decision-making process. So, although the sample size was small, the findings highlighted a consistent pattern that suggested a knowledge and process gap rather than isolated errors. The audit revealed that inappropriate PICC use is not just a procedural issue, It's an education and communication problem. From a clinical perspective, unnecessary PICC lines expose patients to avoidable risks such as infections, thrombus, and delays in care. From an operational perspective, each misplaced line adds cost and workload to already pressurised vascular access services. And from an educational perspective, it's clear that both surgical nurse practitioners and junior doctors would benefit from structured learning about referral criteria, TPN indication, and early MDT collaboration. This aligns with the broader NHS agenda of improving quality through education and cross-departmental teamwork. By improving knowledge and creating a shared understanding of referral pathways, we can enhance both patient safety and resource efficiency. So, what was our recommendations and next steps? Based on these findings, we proposed several key actions. To introduce mandatory PICC referral education for all surgical staff involved in requesting and approving lines. This could be a short e-learning module or in-service training led by the vascular access and nutritional teams. Collaborate closely with the nutritional team to ensure early review of potential TPN patients and reduce unnecessary line placements. Develop a standardised referral checklist for surgical nurse practitioners. This would serve as a quick reference tool to confirm that the clinical indication, duration of therapy, and nutritional plan had been reviewed before submitting a referral. And finally, re-audit. After implementation, to evaluate whether these interventions have reduced inappropriate referrals and improved communication. In doing so, we hope to establish a more streamlined, evidence-based process that supports both staff confidence and patient safety. Reflecting on this project, we found it particularly valuable to see how small gaps in understanding can lead to significant clinical financial consequences. As an advanced clinical practitioner, this experience reinforces the importance of education, leadership, and interprofessional collaboration, which are key pillars of the ACP role. It also demonstrates that sustainable improvement often comes not from introducing new technology or policies, but from ensuring that staff across all levels share the same knowledge base and expectations. To conclude, our audit has shown that around 1 in 6 PICC lines placed within our surgical divisions were inappropriate, largely due to uncertainty around TPN criteria and limited early involvement of the nutritional team. Through targeted education, structured referral process, and closer multidisciplinary collaboration, we can make meaningful improvements in patient care, operational efficiency, and professional development. Thank you for listening. I hope you enjoyed our short presentation. Thanks again. Bye.